like to introduce a complete TTE guided leadless pacemaker implantation. Yeah, we know we have two types of leadless pacemaker. These two types leadless pacemaker are implanted and there's guided by X-ray. So we need to use the catheter room and the DSA equipment. Of course, the current guidance by Flora has some limitations. Doctors need to have the protection equipment, and also for patients with pregnancy, the limitation. We know the limitation is pregnant female patients are contraindicate the Flora. For some patients, we know the in fact, echo may make sure the position of the pacemaker location in some CT or echo. We found the we in X-ray we think it's in the septal position, but in CT and echo we found it's in free wall. Now some interventional procedure are performed in TTE guidance in cardiovascular field. So we think maybe the leadless pacemaker implantation might be performed by TTE. The feasibility were explored, and also the TTE guidance may have several benefits for patients. Renal failure, we don't need the contrast, and for pregnant women, no hurt from the X-ray, and also the echo can have the real-time monitoring for cardiac structures and give us the true location, whether it's on the septal or free wall. Here I'd like to show two cases of micro implantation guided by TTE. Here's the case. It's just a male case, and the diagnosis was intermittent AVB. And also the structure of the heart is normal. Here the echo showed its normal structure, and the ECG is also normal. But the long time heart monitoring showed the intermittent AVB. This patient accepted the implantation of micro leadless pacemaker. We choose the micro AV. The common procedures on the floor, but for this patient, we try the TTE guidance. I think the key tools for the TTE guidance is this penna-stave guide wire. You see, it's a special guide wire. The tape of the guide wire is very soft and like enlarged tape, and also the guide wire, the main part of the guide wire is very stiff, can support the introducer insertion. Yeah, here we show the imaging of echo. Under the guidance of the panel stave guide wire, we can see, first we insert the guide wire, we can see the enlarged tape of the wire into the here's the atrium and the IVC. Yeah, you can see it on echo. when we insert the guide wire into the circle, to the atrial, and then we insert the introducer. Yeah, after the insertion of introducer, the micro delivery system was sent to the right atrium, and under the view of the echo, we can see we sent the delivery system to the right ventricle. Here, the view may be different at the apical four-chamber view. Yeah, after that, we can center the tape of the delivery system to the septal, and the echo view can clearly see the tape of the delivery system. Also, we need to check the delivery system was not in the RVOT. And when we make sure the position of the tape and at the septal near the apex, and then we can send to see the gooseneck. Maybe here you can see. Yeah, here you can see the gooseneck, and then the device will release rapidly. And this is the threshold pacing parameters. We can see the threshold is low, and the sensing impedance is very good. And after the procedure, we also checked the pacing parameters. It's good. And then we check the position and the flora. You can see it's on the common position. Yeah, I also like to introduce another procedure. Also, this patient with intermittent AVB and choose micro AV. And first, this procedure was performed under the flora. We can see everything is okay, and we release the micro device, and we found the device cannot work. The threshold more than 5 volts. So we think it's a bad position. We retract the device. And then we use the TTE. We found here there's a muscle. It's a pectinate muscle at the position. So we under the TTE guidance, we sent the delivery system cross the muscle, and also we check it on the floor. And under the TTE, we release the device, use the gooseneck, and this time the threshold and impedance is good. The implantation procedure are different between micro and Avir. So we also try the Avir implantation under TTE guidance. Yeah, this is the patient's data. A male patient, and this patient has lots of disease, especially has the chronic renal failure. Disease, and so we think maybe we can use TTE guidance and no contrast. This patient choose the Avir. Yeah, maybe here we can see the wire, the panel staff guide wire. We use MP cassette outside the staff guide wire and insert to the IVC. Here also we can see the guide wire to the IVC. And then we send to the introducer. Also, at the view at IVC, we can send the delivery system to the IVC, the delivery system at the IVC, and then we pull back the introducer to make the communication with the aware VR. And also here we measured the impedance at the IVC. And then we sent the the device into the RV with at the apex 4-chamber view. Yeah, here and we will send the position maybe different different from the micro. We need to send the there to near the apex. And enter the view, we can see the TV position. So I think it could check whether the device will influence the TV function. Well, we know the micro implantation, we need the goose check, but Avir, we need to screw it. And the flora, we need to see the marker of the V in the body of the Avir. But in the echo view, we can't see the mark of the Avir. We don't know how many circles we screwed it. So before we try this procedure, we calculate many procedures and the flora, and we found most Avir are screwed maybe 14 or 15 clicks. So in this patient, we first in the mapping, we see the current injury. I think the current injury, the injury current is very important to see whether the connection is good. Yeah, under the view, we also can see the distance between the tip of the device and the septal, whether they connect closely, and also we can see the current injury. And then we screw the device after 10 o'clock. In fact, we check the current injury at 4 o'clock, 8 o'clock, 10 o'clock, and also to the 15 o'clock, we see the injury different, and also we check the impedance increased gradually. And also we see the threshold, the pacing threshold is good. And then we release the device. After release, we check the pacing parameters, and also we check the current injury. It's okay, and the pacing threshold is 0.5. And we check the view on the floor. So summary, I see these cases just try the procedures. Maybe our cases showed the implantation of leadless pacemaker, and the guidance of TTE is feasible and relatively safe in some cases. Here, I'm not saying all cases. We need to check whether the TTE is good for the cases. If it's the case is very fat, maybe the TTE you can't see a good view, it's not suitable for this guidance. And also, this procedure needs a learning curve. We need to practice it under both the TT and X-ray guidance to make sure the safety. And also the key point of the procedure need to be standardized in the future. We are doing these works. Anyway, this technique provides a novel and effective method for patients contraindicate X-ray or contrast. Also, for physicians, could avoid the radiation damaging. Thank you.